Hi, everyone. So I will definitely have enough time to get through my few slides. So I'm going to talk about pharmacologic therapy for type 2 diabetes. And when I start any conversation about pharmacologic management and type 2 diabetes, I like to start off by talking about the pathology associated with type 2 diabetes. So you can go to the next slide. And the American Diabetes Association had this great image of the ominous octet, which I'm sure many of you have heard of or have seen some literature about. I think there may even be an egregious 11. At one point, there was the triumvirate. So this has taken many different forms over the years. But what I like to focus on and why I use this image so often is because I like to know that there are many different things that we have to address with diabetes. There's not just one thing. It's not only the pancreas. It's not just the liver. There are many different organ systems that are potentially causing a patient to be sitting in front of us with this diagnosis. And even if your picture might look different or if there may be some additional things added, the core and the gist of this is that there are a lot of things going on, and oftentimes we might need to address more than just one. To the right, there is a little box that has different numbers showing where some of these agents that we use, SGLT2 inhibitors, DPP4 inhibitors, metformin, TZDs, GLP-1 agonists, where they might work in this picture. And again, you may see an image that looks a little bit differently, or you might see that certain things are addressing different organ systems. I use this a lot when I teach my students on rotation because I need them to understand why you might see someone on 3 different medications, or why, if we're considering the addition of something else, that we're leaning this way as opposed to this way. Because I think it's important that we consider the full patient, the full scope of what these drugs can do when I'm considering adding on therapy. So if I can address the pancreas, the liver, the intestines, the brain, the kidney, if I can address those different organs, then I have a better scope of, okay, now maybe I can get to what's going on wrong with this person. I may not know if it's the kidney or if it's the pancreas or if it's this, but I know that by putting on different agents that are doing different things, I'm able to cover more ground with these medications. Next slide, please. And so this is the treatment algorithm from 2021 ADA Standards of Care, and this is updated every year. The first of the year is one of my favorite things to do on New Year's Day. Open up the new standards and just like, oh, let's see what's different. But I always inform my students again, like just to be mindful of the changes from each year to year. This is pulled from section 9, the pharmacologic management section. And this slide has changed so much since 2017. Every year there's a new facet, it's arranged in a new way. I know just from going from 2020 to 2021, there was initially the heart failure CKD was in one section, and now they've separated those. And so there is ASCVD risk, heart failure risk, and CKD risk. And that allows us to select the right agents for the right patient at the right time. When I first started teaching diabetes to my students, we had, I remember, I think it was 2017, and it was just like a little box. It was the easiest little chart to teach. So it was like, oh, this is great, this is easy. And now I'm like, okay, guys, let's look at this chart and let's see exactly what it's saying, because it's gotten so much more detailed. But that's due to cardiovascular trials, heart failure trials, CKD trials that have proven to have efficacy associated with some of these diabetes agents. And this is it's a great phenomenon that we've kind of come up on, and it's important for us to not just haphazardly just pick a drug, but to know that there is a stepwise approach, especially for these patients who may have these additional comorbidities, which is super common in diabetes. So whether it be ASCVD, heart failure, or CKD, I feel a little bit better about knowing what agents to select based off of this algorithm. So again, there have been some minor changes over the last year, but still overall, the gist of it has been the same the last 2 years. Especially if you look on the right side, if a patient doesn't have ASCVD, CKD, or heart failure, we still need to pay attention to some factors, and we still need something to guide our decision making. That's a big piece of what I do when I'm doing my clinical pharmacy services is, okay, if I'm making a recommendation, what's guiding my recommendation? Yes, the patient might not have these other comorbidities, but is there hypoglycemia that we need to minimize? Is there weight gain issues, or do we need to promote weight loss? Is there a cost issue? I know in our last ECHO session, we spoke about TZDs, and sometimes TZDs get a bad rap. but they do have a place in therapy. They're still in the treatment algorithm. If a patient needs to minimize hypoglycemia or if cost is an issue, we can look at TZDs. We need to consider our agents that are very highly efficacious, metformin, GLP-1 agonists, TZDs, sulfonylureas, and making sure that wherever the patient is, we're selecting that correct therapy. So even if we have multiple options, we still need to consider, okay, this particular person, A1C is 9. I need to consider something that's going to get that person closer to goal more quickly than something that might not. Even if it's the best drug in the world, if their insurance doesn't cover it, we have to go with something that's a little bit more cost efficacious and work that plan the best way that we can for that particular person. So I really like this guideline, this algorithm specifically, even though it looks a little bit busier, I think it does assist with the treatment options and just selecting what's best again for each person. Next slide, please. This is another great slide from the standards of care, the pharmacologic considerations slide, and this has changed a great deal over the years as well. This is something that I'm using specifically when I'm trying to decide not just on a class, but a particular drug in a class. So this chart is great at having different indications, such as like a plus or a double plus to show FDA approval or a proven benefit. So if I know that a patient needs an SGLT2 inhibitor and they have heart failure, which drug am I going to lean more towards since we have multiple agents? So this is super helpful for just kind of getting down to the nitty gritty of, okay, what is the best option even within this class? And then I'm able to go to the formulary and see what's covered per the patient's insurance. And that usually becomes the driving force, is what, even though I know what the best option is, can the patient afford it? And even if a patient can't afford a specific drug that may have that FDA approved indication, I know that many of these clinical trials, even if it's not specific to the drug, there may be another drug that has similar efficacy, even if it's not FDA approved. So it's so important to know these evidence-based guidelines and these cardiovascular trials that are out there so that you're able to make the most effective and the best recommendation for each patient. I also use this when I'm talking to patients about additional considerations, or is this the best drug for the patient? Would they be inclined to not perform well underneath this agent? So I really like this slide to kind of like just double check myself as I'm considering making recommendations for particular patients. And I always make sure I look at the bottom at that chart, because again, this one has updated since 2020 and of course since the year before, with some new drugs who've gotten new indications based off of clinical trial data. Next slide, please. I'm gonna wrap up real soon. So just a few of the things that I like to consider in regards to pharmacologic treatment or management of type 2 diabetes are available combinations. There are oral combinations, Invocamed, Janumet, multiple of those that exist. There are also some insulin and GLP-1 agonists. So there's like Soliqua and Zatofi. Oftentimes these may not be covered by insurance, but it's not bad to check just to be sure. If we can do 2 injections in one, even if the patient is doing an injection every day, that's a good benefit to have both of those in one. And even with the oral meds, if I can put in a DPP-4 inhibitor and metformin, I'm covering many of those different organ systems, going back to that ominous octet, by just having 2 drugs in one. So we're thinking about increased adherence. We're thinking about better patient compliance with the medication regimen, and hopefully decrease polypharmacy, looking at the number of drugs or injections. Cost, I'm big on cost. I'm from rural Louisiana, so I know that people will not pick up things that they can't afford. And if it came down to food and medicine, food will win. So not being mindful of that and using the patient to be a part of the plan making process, and saying, hey, like if we can't do this, we're going to do this, and we're going to keep working this thing until we get a good plan. Thinking about beginning of the year drug changes. Oftentimes, patients go into the donut hole very early, and things that were covered last year may not be covered this year, or they may need to meet that deductible. So we have to be okay with making some switches when that might be necessary. Optimizing therapy. So a lot of times when I'm working in retail, I see that patients are at the same dose that they've been on for years. Even though their A1C is increasing and other things may be going on, that dose hasn't been optimized. So making sure we're doing that even prior to adding on new drugs. Considering side effects and talking to patients about them. I've had patients who have completely stopped GLP-1 agonists because of nausea. And reminding them like there are ways to mitigate that. Let's talk about how we can go around that so that you can get the best benefit from this drug. Adherence, super important. Explaining to patients why you need to take your medications at the same time every day or every week, whatever that might be, to make sure they're understanding their role in it. Like, this is your responsibility. Your doctor can write it, I can give it to you, but you have to take it. You have to eat right. You have to tie in all these other things as well to assist you in your health. And then adding and removing therapy, being okay with and explaining to the patient, look, we might have to add something down the line. We might also be able to remove something. And I think we just need to be okay with having those conversations with patients, just telling them like it's a fluid process. You might not always be on metformin and Januvia. You know, if insulin might come into the picture, it might not. But I think just having those honest, open conversations when we're creating treatment plans for patients just makes it flow better over time, because we do know that these patients are generally with us for a long, extended period of time. I think that's the end of my presentation. I'm sorry if I went over. Any questions?
Great presentations,
Yeah.
Raven. I mean, you
Yeah.
did a beautiful,
Great.
beautiful job, and you covered so much in so little time and so little slides. This is amazing.
Yeah, that's great.
Thank you.
Yeah, thank you so much. Like everyone said, super informative and provided some great resources that I'm sure will be useful for everyone.
Yeah. Any questions for Raven? Well, we have like 2 more minutes, I think. No, okay. And I would definitely like to echo, kind of ask your patient so if I put you on insulin twice a day, will you do this?
Mm-hmm.
Or if it's insulin once a day, when are you good at taking this? Are you going to be good in the morning, or do you think you'll be good in the evening? So kind of have them tell you what works for them. Because if you are deciding what works for them, it's not going to end that well, probably half of the time. And so half of the time is not good enough. So definitely kind of, and expecting, kind of telling them, hey, I expect you're going to have some nausea. Just stick with it, do this, do that, whatever. So definitely preparing them for the plan. So they know what to expect, when to call you, and those sorts of things, I think work well for adherence. So great. Any questions? Last chance.
There was one question about the slides, the presentation slides would be available, and Danae did answer in the chat that the slides will be available on our website and recording of the presentation as well.